¿Cómo? Femenina. Child C. Oh, puta. Hello. Si hay invasión portal aquí. Mira. Hello. So, good afternoon. So we have an interesting case today. So first and all, I will say the happy 2023. So this year we will have. No sé si nos estamos escuchando. So this year we will have our endoscopy and gastroenterology congress in June. So you are welcome and invited because we will have new technologies to show it, and for the first time in real time, for people that will assist, they will arrive to see in virtual reality front our rooms um, this new technology and how to deal with this and how to use it for live procedures and also live transmission. So we have today one pancreatic mass with complete obstruction of the biliary tract and also of the main pancreatic duct, but the lesion is, I believe, is 4 centimeters. And this lesion is in a 74 years old woman. 74 años, ¿verdad? And it's not just an obstruction. She have already liver cirrhosis, and also we have a cholecystitis here. You see, so probably because of the main pancreatic duct, main cystic duct is with an obstruction. So the thing is, this patient have a child C, and it's not more resectable. So we need to deal with this patient. We already do a elastography, I believe, and share wave and contrast with DFI. You can see here is very hard lesion. You see here the obstruction also of the biliary tract. So we have 9.92 for elasticity, and we have no contrast captation. You see with DFI technology that we supply will replace in the future the contrast. We are under evaluation of this. So today I will show you how to deal with this kind of patients. I believe it's a complete obstruction of the biliary tract, so it will be very difficult to do a ERCP with drainage, and so I'm trying to do a bit of drainage here because I believe will be quickly, easier and faster, and I will use and I need also to do a drainage of the gallbladder because this patient have a high risk to develop complication because of cholecystitis. So I am inside, you see, very well. Easier. I am using a Microtech needle, 19 gauge needle standard. I do an aspiration just to confirm that I am inside the biliary tract. You can see here in the camera. So for me, it's very sure that I am inside, and I prefer to do using a guide wire under a guide wire technique because of the risk of with ascites to develop a complication, you know. So we have a patient with ascites, and even if this have ascites is not is not an absolute contraindication. It's a relative contraindications to do biliary drainage. So we can deal with this. Some cases you need to perform ascites drainage we need to evaluate also if this patient have carcinomatosis or no. I didn't see so any nodule inside, but there is a risk, you know. So you see the gallbladder is there, but there is a cholecystitis inside. So I necesito ver abajo agua. So now I will use a guide wire. Okay. Dame. So I will use a 0.035 guide wire. You see, in spite of contrast, there is not contrast in the small bowel, so this patient have a complete obstruction of the pancreas. It doesn't mean that it's impossible to do an ERCP. It means that will take more time and probably a little bit more difficult. Okay, let's see. You see, I arrived to pass a little bit. Okay, so no worries. Okay, empuja. Empuja. Okay. So now I will use a hot access for drainage. Biliary tract is a small one. Okay, see. The 8 millimeters is hot access. So I believe there is pus inside the gallbladder because of the consistency of and what I am looking inside during the endoscopic ultrasound evaluation. So now so this is very important to see also the guide wire. You see, it's very important to see very well this guide wire, because of the communication. It's very important. And I have the space, I believe, to do a good drainage. A small axis is okay. Ana. Ok, despacio, ten ahí. Ten. Cuidado se te viene. Cuidado. So now I'm ready. So you can see, always trying to look in the guide wire very well. Now I am very well. I am inside, you can see here. So now I will deploy it. I am opening it. I try to push to open very well. You see, now it is very well opened. So I'm sure that this is very well open. Ten aquí. Cuidado, no mucho. So I am pulling a little bit. Now I am opening. So we see the communication between the biliary tract and the intestinal lumen. Okay. And you see now the axios by endoscopy. I don't know if we there is the bilis coming up. So now, even by fluoroscopy, you can see very well. So I'm sure that I'm very good place my biliary drainage, and showing you that it's not a well, it's a relative contraindication. So no worries with this. So we are looking the bilis coming. I want to see my axios now. Is there? You see? It's perfect. So I want to take a picture just for the records. It's there. There is the axios. You see? Okay, we will see better in a few minutes. I want to continue to do my so you see the gallbladder here, so it's thicky. There is a thickness of the wall 3.6 millimeter. There is a lot of sludge, but I believe this is pus, so I will use a 10 by 10 axios. Dame un axios de 10 por 10 por favor. And with this we will solve the cholecystitis in this patient. So you can also use the guide wire when we have, but I believe we have very good approach here, and I will not, it's not necessary to use the guide wire. So let's put some E-flow to see if there is any vessel. There's not vessel here. So now so there is a question about if this patient candidate can have a radio frequency. That's correct? Yes. Okay, connected. So I believe yes, but we need to understand what is happening with this ascites. If this ascites is because of carcinomatosis, there is not improvement, so no candidate for this. So we will publish that soon, and it's very important that patients with metastatic disease will not be, you know, I don't believe that will be a good candidate because of the results that we have until now. Very good. You see? Very good. So now I am pulling back. Then I so now I do my gallbladder drainage very well also, and it's complete. So now I just want to be sure that this ascites is just ascites from the liver cirrhosis and not from metastatic disease, you know. So we will clean soon, but you see pus here, huh? There was pus here, huh? So for now, I need the 19 gauge needle. I will do an aspiration of the ascites. I will use the US technique here because will be easier, and we need to also to evaluate the, ¿cómo decimos el líquido del suero con en inglés cómo se dice? the gradient of albumin, albumin, and from the serum and from the ascites. So this is the idea. This is where we will do also an evaluation, not just send to the pathologist. Also, we need to do this evaluation. Well, I believe I am inside, huh? Yes. So we're inside, you see here. So I will take 20 cc of aspiration of this liquid. And with this data, we can have a better idea what is happening with this patient and what do we have to do. No, no. No existe eso. En Sevilla tal vez, aquí no. I'm sorry. Somebody's trying to do something wrong. Doing something wrong. I don't know why. So one is for the pathologist and the other one for evaluation, the albumin gradient. Okay? This is very important. So I finish. I really thank you to be with us today. We're having a lot of nice cases, but I didn't have a lot of time to do a live transmission. But today we take our time to join with you this case. So I will close my live transmission and thank you again. Okay. So we will see what happened with this patient. Probably we can do I will evaluate the liver, but we can do probably radio frequency. It will depend on the results. Thank you so much. Cortamos la transmisión. Oh, puta.